by the Faculty of Psychology, Universitas Indonesia. So for today, we have a very great speaker and has a lot of experience, Professor Deborah Turnbull, which is the chair of the Department of Psychology, the University of Adelaide. And for today, the topic will be a research program responding to policy calls to improve mental health and an invitation for international collaboration. This okay? Okay, so Professor Deborah Turnbull did her BA honor from the University of Newcastle and then did her Master of Psychology in Clinical, also from the University of Newcastle, and then graduated from the University of Sydney for her PhD. And today we have people in this room, and also we have people that is joining us through Zoom. Hello. Okay, so hopefully for this afternoon we have a very lively discussions, and we can learn a lot about how to conduct research, how to have the research that is aligned with the policy. And so like the research will have a greater impact. So without further ado, please joining me in welcoming Prof. Deborah Turnbull. Okay, Deb, the floor is yours. Thank you.
Thank you, Kame. So I'd like to begin by thanking the University of Indonesia for inviting me to be a visiting professor. The Universities of Indonesia and Adelaide, we've got a memorandum of understanding. And so it's great to be one of the individuals who keeps that, agreement alive. So today I'm going to talk to you about a topic that is, I think, of global significance, and it's to do with how we can improve the population's mental health. But I'm going to focus on a particular group that you may not have thought about, and that is the mental health of Australian men. And I'm going to explain in a little bit of detail, why this is becoming a real issue in our country. So I would like to acknowledge that the University of Adelaide is based on the land of the Kaurna people. The Kaurna people are the traditional owners of the land upon which all of our campuses are based. And you can see, for those of you who don't know Adelaide, it's down here right in the south. Now that's got implications for some of the things I'm going to talk about today, because it's a city that lies on the edge of a desert, and consequently it is very prone to extreme weather events. And this is something that we're trying to build into our research program going forward. On the this side, this is my students who I brought up to Indonesia last year through a federal Australian government funded study program. And I spoke today with the team, and I'm really glad that they've given me the go-ahead to bring Australian students up to University of Indonesia next year. So my presentation is going to do two things. It's going to, I hope, demonstrate to you how we're trying to really make research of relevance, of consequence. And we're responding to policy documents in that regard. Responding in a way about how, in this instance, we can improve the mental health of Australian men. And I want to show you how it's evolving and how it's changing over time. And the other thing that I want to show you is how we're building our multidisciplinary teams, and also how we're trying to respond to the changing research grant landscape in Australia. It's getting increasingly difficult to find, to be successful in grants, in government grants. And so increasingly researchers like myself, we're turning to philanthropic funds. And I'll give you a few demonstrations of that. And also it's an opportunity for me to invite you to some so nice to see you. Thank you for coming. One of my colleagues invite you to an emerging tri-nation research program that we're developing, particularly around climate change. Let's see. Okay, so this is the I guess the context in which this research is done. This is a multidisciplinary team. It comprises of people like myself, psychologists, biostatisticians, we've got physicians, we've got nurses involved. And basically our goal is to conduct high quality research that takes into account considerations around sex and gender in order to respond to policy calls. And it's funded through the Freemason Centre for Male Health and Wellbeing, which is a non-government, not-for-profit organisation that specialises in supporting Australian men. So on my left-hand side, this is the South... Oh, sure. Oh, thank you. Thank you. Sorry about that, Zoomers. So on the left-hand side, this is the South Australian Health and Medical Research Institute. It's one of the iconic buildings in the city, and it's where most of our team are located. And the theme that I collaborate in is one around optimising health services for men. So you're probably wondering, you know, why is it that men's mental health is such a big issue? Well, just like in Indonesia, we have a significant challenge with mental health. Our Productivity Commission has indicated that at any one time, there's about 4 million Australians out of a population of about 25 million, 26 million, who are suffering from some sort of mental health distress. Now, this is typically anxiety and depression. So, it's about 1 in 5. And here's the thing, many of the people who need it, they don't get the treatment they need. And specifically people who live in rural and remote settings. And another group that's really struggling with, high access to services is Australian men. So I want to tell you about that story. So in 2020, our government announced a National Men's Health Plan. It's one of the very few internationally that exists. And basically, it makes this argument. It makes the argument that we have a health problem with about half of the population in relation to the following. So, Australian men live on average about 5 years less than Australian women. Their susceptibility and their response to illness, it differs, you know, as a consequence of biology, but it also differs as a consequence of differences in access to services. We know that Australian men have got different attitudes towards accessing health services. They're more likely to self-monitor their health and then only go to the doctor when it's really absolutely crucial. And they're also more likely to seek information independently. Now, that is a problem, but it's also an opportunity. And I want to talk to that. So when they go to the doctor, they have shorter consultations. They tend to leave significant problems unattended. So, you know, they'll go in with a cough or a cold, but they won't talk about the things that really worry them. And they're more likely to express distress in bodily form. So they're more likely to somaticize their problems. So I've worked the majority of my career in women's health. I started my career looking at how we can improve access to screening for breast cancer. Thanks, Sali. And so that's okay. And so it took me a while to come round to this issue in terms of men's mental health. And one of the things that really did it for me was a piece in the Lancet in 2019 that basically said that when we elevate on the political agenda the needs of men. We improve gender equality all over, and we better accelerate the response to the Sustainable Development Goals. So basically, the editorial was arguing that when we improve men's health, we've got the ability to improve the health of women, families, and children. So here's the thing. When you go to the statistics from organisations like our Australian Health and Australian Institute of Health and Welfare, it tells you that mental health is a big contributor to overall health burden. Okay. Men, about 1 in 5 to 1 in 8, will suffer from anxiety and depression or depression. The difference is they're much more likely to misuse alcohol and drugs, and they're much more likely to die from suicide. And that means that they don't live as long, okay, amongst other things. We are having, in some parts of Australia, this issue is regarded to as, a mental health crisis. And I'll come back to that in a minute. So the issue is, it's not kind of a competition between women's health and men's health. The issue is that the needs are different. And men are more likely to die prematurely than to live a long time with illness. So they've kind of got a different profile of needs. All right. So for a long time, the argument was, well, it's all their fault. They've just got to go to the doctor more, and they've got to, express their needs better. But in fact, that's actually not really the issue. So these are data that tell you these are men with depression and their healthcare use in the past 12 months. And this is consulted a psychologist, a counsellor, and a GP. And you can see that men with depression, they're more likely to have consulted a psychologist and a counsellor and a GP. So if they're depressed, they're going, they are going. And critically, when you look at the pointy end in terms of death by suicide, that is exactly the same thing. So this is for men who've got suicidal ideation. If they say yes, they're more likely to have consulted a psychologist. They're more likely to have consulted a counsellor. They're more likely to consult a GP. And the same thing happens. Men with a suicide plan are more likely to reach out for help than those who don't. And those who make an attempt are more likely to have reached out than those who have not have depression. So it's not that, they're not going for help. So something else is going on. And the men's strategy reckons that what we need to do is provide services in a different way. We need to kind of reform our health service so that it's more accessible to men. So the possible responses that this group that I am a member of, this is the kinds of work that we've been doing. Can we improve the counselling interaction? Can we, if we provide men's only health services, so, a men's only health clinic, will men go to it? Can we use technology to improve access to services? And the last thing is, one of the groups that we're really focusing down on here is our Australian farmers. Because Australian farmers are at significant risk. Their rates of death by suicide are relatively high compared with the rest of the population. The reasons for that is it's multifaceted. They've got the means, because most Australian farmers will have, say, a gun in a shed somewhere. We know from our research that the mindset of Australian farmers can be really different. They can be very stoic, independent. They don't tend to trust people like me, psychologists. They don't really trust professionals much at all. They really think that they can manage it themselves. So when you get that coupled with the fact that, you know, the services often aren't physically there, it's really a big problem. So first thing is, how can we improve the interaction between the counsellor and the man? And this is the work of Dr. Alex Bray, who just graduated his PhD about 3 weeks ago. And I want to share this. What I'm going to do is kind of share with you a whole bunch of different research, some of which is published, some of which is, you know, ongoing, some of which has been done by students, just to show you how we're trying to do this work creatively. So Alex is a really interesting guy. And he really thought that what happens with men is that when they go to see the doctor or the counsellor, they're often misunderstood. Okay. So how do we, yeah. So let us see. So he brought to me this idea about signaling theory. Now, signaling theory is derived from evolutionary psychology. It's used a lot in business. And basically it goes like this, that there's a bit of a dance that happens. A dance happens between the two people in the counselling arrangement. That is the man who wants the help and the counsellor. Okay, so in this diagram, you know, this is the bird. And this is, so this is the superior bird. This is the inferior bird, I guess. And they're trying to send signals to each other. They're, you know, this one's saying, I want you to take me. No, me, no, me. There's a bit of a dance going on. This one, unless this one gives the right signals back to the right bird, there'll be mass confusion. So it's this kind of two-way interaction. So Alex came to me and said, I want to use this theory for my PhD. And I'm thinking, this is so weird. How can we do this? But he was convinced. So at the bottom line of this, he was not convinced that services were providing the right help. And it didn't take, and the research, you know, it often doesn't take into account the way that men and the counsellor interact. So signaling theory basically says that there's a communication between the man and the therapist, and it's a strategic one. So the man is only going to be confident that the benefits outweigh the costs, such as shame or embarrassment, if he gets the right signal from the therapist. If he doesn't get the right signal from the therapist, he might feel shame and embarrassment and never go back. Right. The therapist has to have the right skills to do that. And yeah, the therapist have to have the right skills to indicate to the man, it's good that you came here. You don't need to feel shame. You don't need to be embarrassed. It needs to indicate that you'll get help without these costs. Okay, so how do we untangle that? Now, I don't know what it's like in Indonesia, but in Australia, there is a huge pressure on students graduating in short periods of time. You know, 3.5 years, 4 years. You can't do same. So, yeah, so I get a student who says, I want to do this piece of work. And the first thing is, how do we get this packaged in a way where they can graduate in 4 years max? Because if they don't graduate in 4 years, then we get punished. Yeah. Because I don't know do you have like a performance chart? We have a performance chart, and I get a black mark against my name. You know, it's so true. It's so true. So I'm thinking, how can we do this? Now, increasingly, what we do is we use existing data sets. You know, the student doesn't go and collect their data. So this is what we did. There was a data set that was available to us. The owner is a collaborator by the name of Zach Seidler, and it's a data set of 2,000 men. These are men with moderate depression, and 72% of them had at least one experience in therapy. And it's an online survey, and it asks them about their most recent experience. And through a series of statistical models, both mediational and moderational models, we were able to find this, that yes, there was evidence that this two-way interaction was important for encouraging men to get help now in the future. So we found evidence of the importance of this, two-way forward and back. And these were the things that were important. These are the kinds of signals: building rapport, clarifying the structure of therapy, and tailoring the language. So because of research like this now, major charities, not-for-profits, like there's one called Movember, they're now developing curriculum for doctors and psychologists, explaining to them what language to use during the interaction, so that men don't go away and then just don't come back. So that's the first thing. Now, the second thing was, would men like it if we provided men-only services? Because the majority of healthcare in Australia, at the primary health level, it happens in a situation where you walk into the clinic and there might be, women's magazines. This was before COVID. Women's magazines on the table. There might be flowers on the table. There might be a little play area for the children to play. There's nothing there that signals to men, this is a space for you too. So they walk in thinking, oh, this is really a space for women and their children. So what would men go if we provided a service just for them? So this was a piece that we published a few years ago. It was headed by Andrew Vincent, who's the biostatistician in our group, a multidisciplinary team. And basically we wanted to know, if we made this health service, would you go? And this is what we found. 1,500 people, we randomly surveyed them, and we found that 70% said that, yeah, by and large, they think they would attend. The main reason for not attending was that they were simply happy with their existing doctor. And the ones who were probably, best suited for this service were the younger men, insofar as that the young men, we thought that marketing the idea to young, healthy men might be a good idea, because they're the ones who the data showed us were more likely to have behaviours that are associated with not attending or delaying. It was the young men who were more likely to say that they would delay or they would avoid getting help. All right. And then the last question is, well, can technology be used to better serve our community? I think everybody here knows about e-mental health. It's absolutely ubiquitous. And we were particularly, every time I come to Indonesia, I notice so many similarities between what's happening. So the Productivity Commission, this is an independent advisory committee to the federal government. They basically argued, yes, we need to use technology more. And then I know in Indonesia, you have the idea about realising Society 5.0 and putting technology at the centre of the community space. So I was really, intrigued by the similarities there. So this is a piece of work. I've got 2 or 3 to share with you. The first one was about helplines and what kind of men call these helplines. So it's called Health Direct. It's a publicly funded service. And the idea is, if somebody, it can be anybody, has got a worry, they call up, and it's staffed by nurses. Yeah. You've got a similar thing in Indonesia, I think, with this one. Yeah. Yep. So we wanted to understand what kind of men call the helpline and what were their concerns. What language did they use? So this is a piece of qualitative research. where we analysed the conversations between the men and the nurses, because we thought if we could understand the kind of conversations they're having, we could use this to train the nurses in the future. So, analyse the conversations of 196 men. And basically, we found that there are 3 different kinds of main conversations that they're having. And they are as follows. There's the reluctant caller, the one that says, actually, I don't really want to be calling you up. I'm just doing it because my wife wants me to. Then there's the unwell patient. These are typically men who know a lot about their own health. So this is an example, the dialysis patient. You know, he knows a lot about his own health. He knows, he's gone home, he's shivering, he knows he needs to get help. And then the last one is basically what we call the concerned carer. This is the man who is concerned about someone else in the family, in this instance, the 2-year-old son. So we think by analysing those kinds of conversations, we can use that information to inform the nurses about the kinds of things that men will call up for, the kinds of things that they will say. So there are tens and thousands of online tools and apps for mental health. We wanted to know, is there any evidence that these things work for men with anxiety and depression? And so we did this is a meta-analysis. So it's a systematic review and meta-analysis. It includes 9 studies over 500 people. And we found some positive impact for depression. Wasn't very strong, but there was some evidence that these kinds of tools work for men in addressing depression. So that was of the quantitative data. And then what we wanted to know is, well, what kind of thing do men like with these apps and these online tools? What are the design features? So again, we did a review, in this case, of 8 studies. These are all qualitative studies. And we identified the main design features that are important for men. And it's probably not, it's probably what you'd anticipate. Basically, they were saying that they want the apps to be very action orientated, to tell them what to do, where to get help. They don't want necessarily a lot of information about, feelings and emotions. They basically want to be told how to take action. Time is a barrier. Experience is a barrier, and you have to build something that is really super easy to use. Okay, so by doing these 2 reviews, one of quantitative work, one of qualitative work, we could find out, yeah, these tools probably will have a role. And going forward, these are the things that tool builders need to take into account. And finally, as part of this story, how to reach farmers. They're a hard to reach group. So this is a map that shows you the access to our national insurance scheme for mental health distress. Okay, we have a national insurance scheme, I think like you do, that you can actually get free services for mental health distress if you go to a registered provider. And this basically shows you that the majority of these services, they're used in a very small amount of the country. When you get to the regions in the outback, which is kind of, this is where I live, right? Around here. But when you get into the bush, the services people aren't accessing the services. So we were motivated to develop a tool based on acceptance commitment therapy just for farmers. Basically, giving them a free online tool that they could use when they're out in the farm to give them ideas about self-management. It's called I Can Farm Well. And the first piece of work is basically addressing, did they like it? Okay, because if they don't like it, it's unlikely to make any impression on mental health. So we did interviews, we did surveys, and we found basically a really good, if, 5-star rating is perfect, we were getting about a 4-star rating. So really very happy with that. But just because they like it doesn't mean that it's necessarily going to improve mental health. So the next thing we did was basically a study, which is a before-after study, seeing if compared with before, afterwards they were feeling better. And, notwithstanding the fact that, there's lots of, limitations on this particular design, we found that distress decreased, mental health increased, the effects were maintained at 6 months, really good satisfaction scores, and the majority of them would actually tell their friend that it's a good tool. They'd recommend it to another farmer. So, in summary, we tried to address 4 questions, and we've done that using different kinds of research paradigms, some qualitative, some quantitative. And in each instance, we're using the research to try to inform policy and service design. This is where I want to take it next. Every time I come to Indonesia, I'm struck by, we've talked a lot about the similarities in our countries, but I'm also struck by the differences. Australia is a highly individualistic society. Indonesia is not. When I come to Indonesia, things just happen. The stuff gets done because people work collaboratively and cooperatively in a way that we don't seem to be able to do because, we're so focused on ourselves as individuals. And, there's good research evidence that shows that there are differences in our cultural characteristics that way. So here's the thing. When you look at the global statistics for things like depression is lower in Indonesia than Australia. Why do you think that is? Family, connection to spirituality. Yep, you are connected. I am really convinced that that is a huge contributor to the differences. So if you look at Australia, we're becoming less connected. It's really awful. Whoopsie, keep doing that. All right. So I became really interested in the notion of loneliness. It's really getting a lot of traction in psychology and within the policy domain. So this is a major piece that came out last year. If you want to learn about loneliness, everything you need to know is in the US Surgeon General's report. This is really fascinating because the US Surgeon General, he'd be about my age, and he reckons that he never would have thought when he started his career that loneliness would be an issue. Okay, same, never occurred to me. I had to go and look up what it was. Basically, it's a subjective, distressing experience. It's one that, there's a perception of isolation where the connections you've got are not what you need. So it's this discrepancy, it's an unmet need between preferred and actual experience. And there's really compelling evidence that there's a bi-directional relationship with anxiety and depression. And it's on the rise. And it's on the rise in my country, and I want to show that to you. So this is connection with important people, people that you love and care about once a week, 2 or 3 times a month. You can see it's going down in all age groups. You know, in the young, in the 65 plus, it's going down. You know, people are, and it can't be, I think, entirely accounted for by COVID, because it started to happen prior to COVID. So, yeah, please. Yeah. Oh, by all means. Yeah. So this is from the year 2001 to 2021. And this is connection to others 2 or 3 times a month. And this is about once a week. And it's going down across the board. Yeah. Yeah. I think the question is about connection to, you know, people in you. Yeah, meaningful people. Yeah. Yeah. It's certainly not, you know, connection to Facebook friends. Yeah. 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 No, no. I think it's just a measure of connection. Yeah. Yeah. Thank you. So there's pretty good evidence that social isolation has got significant negative impacts for us mentally. And the US Surgeon General reckons that that's probably particularly the case for men and risk of suicide. So we're sort of putting all of these pieces together, and we're working in the community centre space. This is a community centre in the Adelaide Hills, where I live, and I'm on the board of this centre. And we've got grants, both university grants, but also community-based grants from our state government. We started to look at connection with midlife women, and now it was interesting, we started this project, and then the men said to us, but we want to be involved too. And then we got a grant from our state government to do work just with men. So what we're trying to do is kind of take this out of the medical space, even take it out of the health space, and put it into the community space. So this is the last part of my talk. So I've tried to explain, you know, a piece of research that's been running for many years now, multidisciplinary in nature, funded through a lot of philanthropic money, talking about how that it's growing and developing. And then I want to finish on what we were talking about this morning with the team here at UWI. So I'm thinking about, you know, my career and what's the next thing that I want to do. I feel like, you know, mental health, I want to continue to work in mental health, but I do want to put it in a sort of a population context rather than necessarily in an individual context. And I'm really struck in this instance by issues of significance like climate change and extreme weather. So this is where we're going now. So this gives you an idea. We started to collect records, heat records, in 1910, okay? And you can see this is sea surface temperature, the blue line, and this is air temperature, and it's just skyrocketing. Now, we started to have bushfires on record in 1936, but what's happening now is they're getting more frequent and they're ferocious. The bushfires that we look at now, they can be up to 100 kilometres in length, and they are really scary. And they're really scary when you live in the south. But it's not just the fires, it's also the floods. So when I was up in Indonesia this time last year, we were going to go out to a village. We couldn't go out to the village because of flooding. It's happening with us too. If you look at rainfall here, this is the highest on record, very much above average. In the north, we're getting higher than average rainfall. In the south, we're getting the lowest on record. So the country's kind of in this, you know, dual crisis. So There's been a Royal Commission, and it's telling us, yes, that these issues are accelerating. There is very good meta-analytic evidence that there's significant when these kinds of exposures happen, it elevates distress. And it's not just direct exposure, but it's also indirect exposure. You know, reading about it in the newspaper. I know that echo anxiety, it's not a diagnosable condition, and there's a lot of conjecture around it. But we had major fires about 5 years ago, and I can tell you that even though I wasn't directly exposed to them, I think it had a psychological impact on me, just knowing that my community was being impacted. The other thing we're becoming more familiar with is in Australia, a really important pressing issue is family violence and violence against women. And the research tells us that those acts, the risk for those acts are elevated during extreme weather events. Yeah. So there's lots, become emotional deregulation, dysregulation, there's also evidence that there's physiological impact at the brain level. And so it's got a lot of possible consequences. So I've been running yes, you know, many of you will recognize my friends here. Yeah, we have been working, I reckon, for about 3 years now to kind of develop this loose collaborative of friends who work on this project together. And I brought up my students last year, so we were able to talk about it. So these are the people from Leeds, and they're going to be coming up to University of Indonesia next month, I think. And then we have my friends Zia and Ridwan from Brawijaya. And then we have my friends from Udayana. Yeah. And we've had some successes at each of our universities getting internal funding. The topics that we're dealing with, we're using multiple methods. So doing systematic reviews, but we're also really interested in using implementation science, taking high quality evidence and implementing it. And we're looking at 2 topics to begin with: better understanding the health and mental health implications and the psychological risks. And also at Brawijaya, they're doing lots of work on psychological first aid. So we're trying to learn from Brawijaya about what they're doing. They've got student volunteers who go out into the community for developing psychological first aid. And we're trying to understand better what they're doing in the hope that we can do that with our students. Okay. So what I've tried to do is threefold. It's to give you an overview of some research that we're doing on mental health, particularly with men. You know, a group that ordinarily you wouldn't think of, but there's quite compelling reasons for us to do this. I've shown how we're trying to continue to evolve this program, you know, going from perhaps a mental health perspective more to maybe a social health perspective, looking at redressing social isolation. And finally, this is an invitation, I think, to you all, anyone who's interested in, you know, finding out about this collaborative. University of Indonesia has expressed to me this morning that they're interested in probably partnering on grants going forward. Then yes, I invite you to join us. So, terima kasih.
Okay, thank you very much, Deb. It's a very interesting presentation. So we have this Q&A session. Is there is there audience in here that you want to ask questions, or audience in the Zoom that wants to ask questions as well? Yes, please, Mbak Ori. Thank you.
Thank you, Aline. Thank you, Deb, for the presentation. May I ask first, because I have to go at 2. Uh, yeah, let me tell you this. This morning, just this morning, I hold a student's hand that he just showed me his um, self-harm that he did, that brought him to, his intention was to kill himself this morning. So when you said about how this is an epidemic that we need to do the work together, yeah, it's not only touched my brain but my heart. For your information, I work with the companies, and in Indonesia now, the Minister of State-Owned Enterprise has instructed that every state-owned company provide report of the employee well-being of their company. Yeah, that's beautiful. But I don't. I'm thinking, what can we do to help them with the how to what do we need to report? Is there any useful, simple, but not simplistic uh, things to be reported, especially for companies and in a male-dominated company, because you are interested with men, and yeah, because what the students that I met this morning uh, is a man. Um, for some companies, you talk about connectivity. Many organizations require their employees to work. They have to move from one area to another area. So they are apa namanya?
We call it fly in, fly out.
Yeah.
Yeah.
So they don't meet their family, right? So I'm thinking, do you have any interest to do research in that area in a male-dominated organization, from state-owned enterprise? Why state-owned enterprise? It's because that the minister just sent the instruction, right? This is like a prime time to do it.
Yes.
And it's related to the their mental health and how they are required to move from one area to area to another.
Yes.
What do you think?
Well, we also have this issue in Australia, particularly in the mining industry, which is a male-dominated industry. Men fly in to the mines. They work, 12, 13, 14, 15-hour shifts back to back for 2 weeks, and then they go home for 2 weeks. And there is, I think, some research that's come out of Australia that might be interesting for you in thinking this through. What I think is important for these kinds of issues is that we don't that we take a thing called the social determinants approach, which is about looking at the issue from the perspective of the individual, the community, and the society. So not just putting it all at the level of the individual, but also looking at issues like policy, guidelines, laws, regulations. And the Surgeon General's report, they very much talk about loneliness in those terms. And it's not just about kind of fixing individuals, but it's looking at everything, including things like the way that we design public infrastructure. The extent to which I'll give you a great example. So my mother lives my mother's 94 or so. She lives at home. She's amazing. And there was recently a big complex built by her, built near her, and I took her to it, and there's nowhere in that complex that you can sit down and have a cup of coffee. All you do is go in, spend money, and leave. I mean, what is that? A woman of 93, 94, like my mum, she wants to go out and sit down and talk, and there's nowhere to talk. So it's about those sorts of things as well. Yeah. 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 But I would say if you there may be some Australian evidence from so-called fly-in, fly-out industries that would help you, give you a sense for it, but also the social determinants, which is it's built into the Surgeon General's report. I think that would be really helpful as well, because I think that it's fantastic that the government's looking at it. If they can, accept it, that it's part of their responsibility in terms of the way they regulate work, then that would be great. Yeah. No, thank you.
Okay, thank you. And then we have questions from the chat. No? Oh, okay. So it's not questions from the Zoomies. Okay, it's only like the presence form,
Okay.
the attendance form. Okay. So is there any questions again from the audience in here? Yes, Moko, please.
Okay, thank you for
you.
your presentation. It's really nice. I'm currently working and also been studying in my PhD program about online education, online learning. So
Yeah.
you mentioned about isolation, loneliness. That is one major obstacles in online learning. So do you have any probably a comments or an insight on how can we implement or doing online education that is focusing on the health and well-being of the students and also the faculty members. So we can keep the online education going, but we try to minimize the negative side effect probably. Thank you.
That's such a good question. And this is something that the University of Adelaide and my school are doing more and more. We have these graduate programs. So these are typically students who've already graduated in another course and now want to retrain in psychology, and they come in and they do these certificates over 1 year. They basically condense into 3 years, 1 year, and they do it online. And I must admit, it's very intense. To be honest with you, I'm not sure that there's anything built into those programs for that purpose. I think that the academics who run the program probably try really hard to, monitor the students and respond to needs as they come up. But I don't know that we've got anything kind of built in to them for that purpose. I'm giving a talk later on, I think, to the health psychology students about digital interventions and wellbeing. And I'm going to share with them a piece of research that was done by one of my other students, which looks at online bullying. And the research that I'm sharing with them is evidence that shows it does have an impact not just on emotional well-being, but interestingly on academic grades. Yeah, yeah. So I think being cognizant of all of that is really wise. Yeah, but I'm sorry, I'm not sure I've got anything, concrete to say, yeah, this works. Yeah, yeah.
Yeah, thank you. Okay, so is there any questions? So, yes.
Hi.
Hi, Deb. I see you again.
Nice to see you again.
Yeah, last year we had activity in Universitas Brawijaya.
We did.
Ridwan, Zia, and some friends of mine say hi to you.
Thank you. Thank you.
Yeah. My question is talking about the comparison between male or man psychologists and women or female psychologists in Australia.
Yeah.
Because maybe I can ask psychologists here, the number it's balanced, or the
That
number
is
of
such a good
male
question.
psychologists is less than the
That is
number
such
of
a good question.
women's psychologists.
Yeah.
Maybe women.
Yeah.
And the women psychologists is
Yeah.
more yeah, does it affect on the, the willingness of men going to psychologists?
Yeah, sometimes I reckon it does.
Yeah.
I reckon this is such a good question.
Yeah.
So,
Thank you.
firstly, in our master programs, we take into the clinical masters, for example, about 10 students every year. They all look the same to me. They all look the same. They're Caucasian. They're typically from fairly middle-class families. They've probably been privately educated, and they're women. And I've constantly said, what are we going to do about this? Because in order for us to serve the community, we have to have diversity. And what I'm finding is, because I teach in the large first-year classes, there are fantastic young men in those classes. They're often not from Caucasian backgrounds. They'll be from culturally diverse backgrounds. And I know they're just what we need in the profession. In my country, 40% of us are either born overseas or who have parents overseas, including me, including my husband, But we're turning out this monolithic workforce. How do we change it? We have these laws, these sex discrimination laws, So we cannot discriminate in favor of men unless we get an exemption under that law. Now, we've been able to do it for engineering to make sure that we get more women engineer students and staff members. Okay, we've done it for engineering. So what I want to know is, could we do it for psychology? And I'm really keen to test it,
Big homework.
Yeah, make it, call for an exemption under the law and see what happens. Because there is increasing evidence that gender-specific services can be very beneficial. Yeah, particularly for men and particularly for young men. And there are gender-specific services. There's one in Canberra called, I think it's called Men Direct, where it's just a clinic for men. And all of the psychologists there are men, and they get good outcomes. Because a lot of the young men that go there, they live in households where they don't have male role models. They're oftentimes from, their mums are single mums. They don't have role models, and it really is really helpful for them to be able to connect at that level. So I think you're onto something here. And one day I'll just be brave enough to test it. Yeah, because what happens is, we've tried so many different ways to improve our selection for the master students. But every year I look at them and I think, another bunch of people who all look the same. And what you find in Australia is oftentimes the young people who are getting into trouble with the law, they don't look like those girls. They do not look like those girls. They're oftentimes young men who come from non-Caucasian, the culturally diverse backgrounds. Very often they're young First Nations boys, and we know that the police pay disproportionate interest in those kids. They're very highly surveilled. When they're out on the street, they frequently will get called by police. And we have laws in Australia that oftentimes permit that to happen. So they get into trouble so much. And then, they might get jailed because of stupid things like fines. They might have not paid a parking fee. And then they go into the jail system, and then they get exposed to, so many psychological distresses. And it's just this crazy kind of, invitation for distress. So to your answer, yes, you are so right on all of those things. I don't know what it's like here. And you're saying that your students are mainly young women? Yeah. Yeah.
Because the comparison between students, women students, female students in psychology, much more than men student.
Yeah.
So like
Yeah.
you can see from this class, there are only 1, 2, 3, 4, 5, I guess 5 only.
It's not that bad.
It's not that
5
bad,
is not that
but
bad.
but
5
from
is
this
quite many actually.
but from the selection of the new students, there is always a consistent pattern that women are more than men in a
Yeah.
psychology student. So I
Same
guess,
with
yeah.
us. Same with us. And you know, those young women, they have a lot of don't get me wrong, they are academically very proficient. They're also socially proficient. They have enormous emotional intelligence that otherwise they wouldn't be there. And they perform really well at interview, you know. And I see my young students in first year, and I think we so need you. But I think you would find it really hard in interview, to being interviewed by a panel and, you know, talking about issues. Yeah. Yeah.
Thank you very
Thank
much.
you.
Deb.
No, thank you.
Okay, thank you. I think that's a very interesting question.
Yeah.
It's because in here we also like have the same problems, like the student, the people that goes into the professional programs, a lot of them are female as well. Actually, unless if they are going to the IO major, it's more like 50-50 or like maybe 60-40 percent compared to like to the clinical program.
Right.
Yes.
Right. Right.
Yes. Yes. Okay. Please, Eta. Yeah.
Hello, Deborah. My name is Etta. I
Nice
want
to meet
to
you.
say thank you for wearing batiks today.
Oh,
You look
thank
so
you for
beautiful in
noticing
batik.
that. Thank you. That's
Not
very
many of us using batik, but you're using.
Thank you for noticing that.
It show you appreciate our culture. I see that your research has a wide scope from gender
Yeah.
to online apa tadi isolation.
Yeah.
And because this is also a section for invitation for international collaboration. Do you have an intention to having a research with topics like cognitive process relate to the mental health or what? So we can have a collaboration together about brains
yeah.
or
Yeah.
because I have interested in that topics.
Yeah. Thank you. That's a good question. I think that there would be members of my school who would be happy to talk to you about. My school's got kind of three threads to it. There's kind of clinical and health, and there's the cognitive sciences, and then there's the organizational and human factors. And we do have a program or a theme, a group of people who work in the cognitive sciences. For myself, I'm really probably not. I don't do much kind of fundamental work. It's all applied. I'll share with you a really interesting story. So, like, if you go to my researcher profile, you can just, you know, Google my name and researcher profile, you'll see it. You'll see it's kind of all over the place. You know, there's a whole bunch of papers here and then different ones here and different ones here. It's probably not, we were talking about mentoring this morning, and it's probably not what I'd recommend a new graduate to do. I'd probably say, look, choose an area of strategic importance where there's money and follow that. Whereas with me, I've sort of gone from place to place. But at my stage of career, it doesn't matter so much anymore because, you know, they don't really care. You kind of, you give it, I think you give them more freedom when you're in the system a bit longer. I think earlier on in the career, it's probably better to plan and be a bit strategic. So it's really good to hear you say, this is my area, this is what I'm pursuing. I think that's really smart. Yeah. Yeah. But by all means, if you want to email me, I'd be very happy to talk. Yeah. by all means, please do. Yeah.
So Etta, she's a clinical psychologist and she works in the hospital, but now she's doing doctoral study in here.
Okay.
Yeah,
Okay.
and the hospital where she works on is the National Brain Hospital.
Okay, in that
Yeah.
case, we would have people who would be happy to collaborate with you. Yeah, by all means, I can put you in contact with people. The other thing too, if you want to have any guest lectures from colleagues of mine, we could organise it on Zoom. You know, if you had particular topics, we could share that way in an ongoing way. One of the things we talked about this morning is our desire for our relationship to be sustained and sustainable and for it to last many years into the future. And that would be one way of contributing to that goal. Yeah.
Okay, yes, that will be
Thank you.
perfect, yes. Okay. Actually, she's my student. I'm her doctoral supervisor.
Okay. 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 Maybe you could give a Zoom lecture for our students, our PhD students. Yeah.
Okay. Yeah. So is there any questions? Yes, please. Yeah.
Yes, thank you, Professor Turnbull, for the presentation. I actually want to discuss something with you about the issue that I've been concerned about. So a little bit of background. I'm working with the radicals, terrorists, the kind where men's mental health goes to aggression. And I'm working on my dissertation that following up the frustration aggression theory. I have this issue. There is this idea that counseling therapy for men is emasculating. Yeah. Yes. So this is the major barrier for us men to approach this, and not just from seeking help, but also the process inside the discussion. So we don't need to talk about our feelings. We need to be powerful. We need to be in control. We need to be a role model. So some stuff that often called toxic masculinity by liberal standards nowadays. So yeah, my experience in the field with these terrorists, I often appear and present myself as someone who has similar identity to them. I came from rural background too. I knew how rural people lives, and we usually talk about similar stuff in this session. Basically, yeah, talking about diversity, we need someone who get their lives when we talk about the therapy, which is not about the psychological process, but also the life settings and identity related topics that we often talk about. Back to the main topic. This is the very thing that I'm concerned of. What about the idea that therapy and counseling is emasculating for men? Is there any different approach when we talk about the problems between men and women?
Thank you. That is such a good question. I'll be really honest with you. I was quite nervous about giving this talk about men's mental health because I was thinking, you know, I was just worried that you'd think, well, surely, you know, Australian men are in a privileged position. Why should we care about that, you know? And so when you talked about to me in those terms, I'm just so glad that, you know, there's a connection there. So there are two researchers in Australia, Zach Seidler and Simon Rice, and they have done amazing work looking at the contribution of masculinity to help seeking. And it's pretty unequivocal. There are systematic reviews that indicate that higher levels of traditional hegemonic masculinity tend to mean that men are less likely to seek help. So it gets in the way of them seeking help, and then it interferes with their counselling process for all of the reasons you've talked about. That was, I think that's one of the things that, coming back to this signalling theory, I think that the thing is that you've got to have a therapist who's able to read those signals that you've just talked about and then send the right signals back so that they don't send signals inadvertently, which is about emasculation. I think you're definitely on the right track here. So yeah, it's well known, at least in Western society, that traditional masculinity can interfere with the help seeking and the counselling process. Now, Zach and Simon, you might want to look up an organisation called Movember, Movember, Movember. It's a multinational not-for-profit. It specialises in exactly the things you're talking about. And Zach and Simon are senior members of that team. And that they've been doing a lot of research in this area. What we're also finding is that sense of masculinity, it's not stable. It changes over the life span. It tends to be at its highest in about 18 to 24-year-olds, which I think contributes to those young men getting into trouble. Yep. And yeah, it's not a stable construct. But yeah, you're definitely on the right track. It is a problem. Again, I'm going to be really frank with you, and I'm probably talking about things, Sali, that you wouldn't ordinarily do. But in Australia, a woman is killed by her male partner every 4 days. Yeah, it used to be every week you'd have one woman dying. Now it's every 4 days. Yeah, it's a huge problem. So I think your work is so important. So important. Yeah. Yeah. You're shocked. Yeah. We are shocked. Yeah. And the way they die is oftentimes it's by violent means. Well, it's inevitably by violent means. Yeah. Yeah. There's a big debate in Australia about the extent to which mental health versus social norms play a role. Okay, so you've got Australian feminists who would say, no, these men are not mentally ill. It's to do with social norms. Because if you label them as mentally ill, it gives them an excuse for their behaviour. Yeah, yeah. So now we've got our government has set aside about $1 billion in the last fortnight to redress particularly homelessness amongst women. And we've got education campaigns. There's also an emerging literature around the extent to which, these group-based, gender-based interventions work. A lot of independent or private boys' schools in Australia have these programs. Yeah, actually, I can send you a paper we've just prepared. If you write to me, I'll get permission from my colleague and we'll send it to you. Yeah. Basically, it's a review of the qualitative literature in this area, which finds that by and large, these programs do have a positive impact on things like attitudes to women, normative behaviours, etc., etc. Yeah. 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 But yeah, just send me an email and I'll send it to you. Yeah. Yeah.
Okay, so I think it's really interesting with this. Is it related to like men are raised with certain expectation to be more masculine? So when they do have problems like related to mental health, it's they'll be perceived as how do you call it, unmanly. So it's not something that they process
Yes.
constructively.
Yes. So someone like Alex, he would argue that the therapist has to send out signals that don't shame the man, that don't embarrass him. Yeah. Yeah. Particularly if he comes from a highly, masculinized background. Yeah. Yeah.
So I do wonder, like in here, I think it's getting better now, but with the boys, when they cry, usually the parents say you don't, boys don't cry. Is that still the same in, is it the same with in Australia?
A lot of people would argue that that would be, you know, part of the differential way that we respond to our children. Yeah. Yeah. A lot of people would argue that, you know, we still treat our boy children and our girl children systematically differently. Yeah. 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 Yeah.
Yeah, sure.
Hi, I'm Angel. I'm a master student here in Universitas Indonesia, and I'm currently doing my thesis around single men specifically, where I posited that men who are involuntarily single, meaning that they are single because they cannot find their they have trouble finding partner, have a greater attitude towards normalizing sexual aggression towards women. Yeah, this was based due to the rising concerns with an online community, which she called involuntary celibates. If you know,
Yes.
I saw that Australia also taking this into a more serious level because they are currently posing threats, violent threats, even to women.
Yes.
And the thing with involuntary celibates men, first, it is found that I saw a research that found that they do have uh, uh, not so good mental health. Their mental health high in loneliness and depression.
Yes.
But their coping strategy goes through maladaptive
Yes.
behaviors, right, into
Yes.
it, normalizing attitudes of sexual aggression or even violence towards women.
Yes.
What I want to know is whether in Australia this has been taken into account, and how if there already any way for you to we have with terrorists, correct me if I'm wrong, we have de-radicalization, right? How do you de-radicalize men who are supporting violence towards women?
That is such a good question. And yes, we do have this issue in Australia. And we have a position called she's called the E-Safety Commissioner. And she's responsible for regulating the online environment. And she would argue that one of the contributors to this is the plethora of pornography online. Yeah. E-Safety Commissioner. She's trying to regulate that in some shape or form. How do we deal with it? A lot of people would say that ideally the way we deal with it is early intervention and prevention, and mass education around healthy normative behaviours. It's interesting to hear you talk about these things in terms of, you know, radicalized behaviours and these behaviours being analogous. You know, and I think there's probably some similar ingredients to them. There are a couple of things I could say. I'm assuming that you're familiar with the work with Ba'ali from Brawijaya. Yeah, yeah. His work, I think, is really instructive, and we discuss his work with my students when we're in Indonesia, because I think it's very important work. The other thing that I'm, you know, constantly amazed by is the qualitative research that's done with the young men who leave these organizations, and they're asked, what prompted you to leave? And oftentimes it's things that I never would have thought about. It's like, well, I just got disenchanted, you know, that the leaders in the organization were saying all of these things, but they actually weren't living by those ideals themselves. So it was just, you know, ordinary kind of developmental disenchantment. One tool that we have in Australia it's a portal which gives you live updates on these kind of instances, where you can go in, and it's funded through a think tank, a liberal think tank called the Lowy Institute. And you can go online and you can look at the demographic pattern of the people who are perpetrating extreme acts and get a sense of their, their backgrounds. I know that some people argue that you have to be really careful with that stuff for lots of reasons, because it can lead to, just making the wrong decisions and discriminatory practices. Yeah. But I can tell you I run a course called International Psychology, and these kinds of things are one of the topics that I do teach, and it's for several reasons. I think from a psychological level, these are really complex and deeply interesting issues, aren't they? Understanding how people can be radicalized, but my government, I know the thing that they worry about is that it can happen so quickly because of social media. Yeah, that's what worries them. So there's the mechanisms and the predictors, and then there's the de-radicalization process itself. Yeah, and the evidence base for that. Yeah. But when I hear you asking me these questions, I think, yeah, this is really good work that you're doing. Yeah, really great.
Yeah, thank you. Okay, is there any questions? Okay. Actually, Deb, I do wonder, like in here, usually with the men, if they have like mental health or psychological issues, they will they don't really, it will take them a while to finally decide to go to a psychologist or looking for a counselor, but they would go to the doctors, and then they will have a lot of psychosomatic symptoms.
Yes.
Yeah.
Yes.
On the other hand, for the woman, if they have like a chronic disease, chronic illness, like physical chronic illness, when they go to the hospital, especially for those from the middle to lower socioeconomic status, what happened is they would like wait until it was really severe symptoms that they have. So sometimes it's hard to like help with their life because it's already like too far gone.
Yes.
Yeah, I wonder if it's the same or how is
Okay,
it?
thank you. So I'm going to answer that by asking everyone a question. So you know how I said that my group is very multidisciplinary? One of my colleagues is a physician, okay, and he specializes in men's health. He reckons that there's 2 questions that the doctor can ask a man about his physical symptoms, which will help to alert him as to his psychology. What do you think they are? There's just 2 things that he or she can ask the man. Nothing to do with emotions, nothing to do with feelings, nothing to do with moods, nothing to do with, health, well, maybe health behaviors. What do you think that'd be? Like what? On the right track. What else? What else? Something that we do every day.
Occupations, organization activities. No.
2 things that we do every single day. What would they be?
Sleeping.
Sleeping.
The sleep.
How are you sleeping and how are you
Eating? Oh no, self-care? No.
Can I tell you? I don't know how well this will translate, Sali. Peeing.
Oh,
going
peeing.
to the toilet.
Okay.
How are you sleeping and how are you peeing?
Oh, that's interesting.
Because there's really good evidence that those 2 things are related to psychological distress. So there's a thing called lower urinary tract symptoms. It's to do with the storage of urine and the voiding of urine. And we've got evidence that there's a bidirectional relationship. Depression can affect the peeing and the peeing can contribute to the depression. So even if the GP is, not trained in psychology and not, comfortable, just asking those two questions, like getting to the somatic symptoms, they're the two somatic symptoms to hone down on. Yeah. And then your question was about women who go and they're overlooked because
they think maybe it's just nothing. It's maybe just because of the stress of everyday life.
Yeah.
So maybe it's not.
That still happens in Australia.
Oh.
There are very celebrated cases that get in front of the press where, a woman's gone because of a severe stomach ache. It's been put down to a functional issue, and later she's been found to have an acute appendicitis.
Oh.
But it's getting better largely because the counterpart to the male strategy document I showed you is a female strategy document, and that's informing health services for women. Yeah.
All right. Okay.
Yeah.
That's very interesting. I mean, like, there's like similarities in terms of how gender between Indonesia and in Australia derive in both people having trying to find access to the medical service, medical assistance, or with the psychological assistant as well. Actually, yeah.
Yeah.
So yeah,
We're not alone.
Huh?
We're
not alone. Yeah.
Yeah.
So it's not that difference because sometimes like with my students or sometimes with people in here, we make like we differentiate, like we make like a different like saying like, okay, people in the Western world, they'll be like this, this, while people in this like Eastern part of the world, they'll be like this. But somehow some things are not that different.
Yeah.
It's just quite interesting.
Yeah, and the challenges that you're facing with regard to things like workforce and, in the future, having fewer male psychologists potentially, absolutely same for us.
Yes. Yeah, I got a lot of questions from like my clients asking whether there are male psychologists for their parents, for their father or for their husband and everything, because like apparently there's not many practicing psychologists that is male.
Yeah.
Yeah, and the one that are practicing usually are very like highly sought because there's just not that many.
Yeah, the waiting lists are horrendous.
Yes. And also like I think why there's not that many male in psychology, maybe it's also the notion that maybe psychological or mental health issue is much more, it's perceived as a feminine science.
Yes.
Yes.
I agree. I agree.
And I just looked at the man audience in here.
Yeah.
Yeah. So
it just came out in my mind. Would it be different between male psychologist therapy room and female psychologist therapy room? As you said that actually there are, women, flower on the table and then girl things. But what about for men? I don't know if there is, special cases in Australia or Indonesia.
I think this.
Or cigarette.
Yeah.
Oh, sorry.
Well, in Australia, we have this notion of cultural safety, particularly for First Nations peoples. So one of the talks I'm giving is about primary care mental health. And there's a real drive in Australia now to make sure that public primary care services demonstrate cultural safety to First Nations people. And it can be something as simple as having the 3 national flags on the desk, not just, so have the Aboriginal flag and the Torres Strait Islander flag, having designs on the wall that are in First Nations paintings and colors. Color is really important in conveying, messages about acceptance. So maybe we need gender safety.
Because it should be a gender neutral therapy room or counseling room for women and men. So it's fair enough for men to go to
Yeah,
psychologists
maybe.
because this is a gender neutral room, so I'm safe here.
Yeah.
Yeah, especially for those who has problem with the wife and the room is very, you know, girly or women. So
That's a good point. It's a good point. You know,
I'm telling about myself. I'm telling about my
yeah.
friend.
Yeah.
You know, like, you know what? Like, if you are telling about yourself, it's fine as well, though.
I'm not married yet.
Is there any relation with what you're just saying?
I don't think so.
I'm just kidding.
For a friend, Sally. Or for a
I'm
friend.
sorry.
Okay.
Thank you, Deb.
Yeah, this is a very interesting discussion. So, do we have any other questions that you want to ask Deb? Well, Deb is here. Like, yes, okay. So there is one questions from the Zoom.
Yeah.
Yes. So I think that's the last one.
Yeah.
Yeah.
Praise
This is
the
from our doctoral student as
Yes,
well.
Ah, yes. Beautiful question. So this question is about, okay, what we're talking about, it's a generational change, you know, changing the laws, etc. What can we do now? And it's about, can we build capacity of already existing female psychologists? I believe we can. And a lot of this work, which is about identifying, you know, using qualitative methods, what men want and how they respond, that's now being made by a curriculum developed by Movember that's going to be spread out to health professionals at a national level. But there's another thing I just wanted to comment on, which I meant to think about when we talked about. There's now a literature that talks about healthy masculinities and using those characteristics that are traditionally, you know, perceived as negative, like independence, stoicism, and using them as therapeutic devices and reframing them in a healthy way. You know, so reframing them about, you know, I can see that, you know, you want to deal with this yourself. And, you know, I can appreciate that. So trying to reframe what you're saying in an affirming manner. And Zach and Simon, they've written a lot about that. They're both clinical psychologists. Yeah. Yeah. So it's this notion of redefining masculinity so it's healthy rather than toxic. Yeah. 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 But I do believe that the curriculum can really do with, you know, some insights into gendering in our training. Yeah.
Okay.
Yeah.
That's really interesting.
Yeah. It's a good question. And I think we're starting to do it. And they're in the process of trying to roll this out, I think, in the next year or two. Yeah.
That's very good to hear, actually.
Thank you.
Yeah.
Good.
Okay. Is there any questions? Yes.
Just out of curiosity, are you familiar with the characters like Jordan Peterson?
Yes, I am.
Yeah,
Yeah.
I wonder what you think about the idea that he brought up to the public.
Okay, well, I think it's really easy, potentially, and potentially problematic when psychologists try to distill extremely complex issues into simple guides. So I'll be honest, I've listened to him. I've not read his book. I am familiar with the fact that he's written one book that refers to, you know, 12 things that young men can do. Okay. not sure that I'm convinced about the evidence base of that advice. You know? Yeah. Like one thing he talks about is, you know, standing up straight, because that does something magical to you. Not sure about the connection between that and, you know, behavior, emotional regulation, feeling of self-esteem, feeling good about yourself, developing good relationships. So, yeah, he's a very polarizing figure. I think in Australian psychology, they'd probably ask the kinds of questions I ask. I mean, what's your opinion of him? I'm really interested.
Yeah, I think he deviates from, let's say, the true science since 2018, 2019. I used to look up to him when he talked about, he seemingly talk about data and leaning into evolutionary psychology, because I'm reading more on David Buss more rather than Jordan Peterson nowadays. I have a quite interest in um, evolutionary psychology, also with my previous lecturer Eric Fettman from University of Queensland.
Okay.
So yeah, but when I'm following Jordan Peterson, I'm looking at him transitioning into someone who experienced star syndrome, I guess. And he makes some points that simply, yeah, as you said, simplifying complex things. But sadly, here in Indonesia, we have this tendency to grasp more and to support something popular rather than something that evidence-based.
Yeah. Thank you.
Mm-hmm.
I think there's probably, and this isn't my idea, I'm reading a book right now by a guy called Alistair Campbell, and he reckons that there's probably two things that are contributing a lot to what we're seeing, popularism and polarization. And I think that when Professor Peterson talks, he inadvertently feeds into that narrative. Yeah. Yeah. So I'm trying to be even-handed and polite. But yeah, I think over time I can't find the evidence for a lot of things he talks about. Yeah.
But so he's like quite a controversial.
Very. Yeah. And I think I can understand his appeal, especially to young men. Particularly to young men who, you know, may not have strong male role models, who haven't kind of been given rules by which to live. You know, the kind of stuff that would have been taught implicitly. I think, you know, as society changes, that implicit learning is changing. Yeah, the community centre that I referred to, I'll give you a great example. So there's this group of young boys at one of the local high schools. They're being raised by single mothers who are doing a fantastic job, and these kids are starting to fall by the wayside. They're starting to, you know, just starting to demonstrate antisocial behaviours. So we've got a group of older men in the community centre, retired guys, and what they do is each of them has been assigned one of these boys, and they go and do woodwork together. So there's a big movement in Australia, it's called men's sheds. And basically they are literally sheds throughout the community where men go and do physical jobs. And as a consequence of that, talk in a way that helps to alleviate mental distress. So they might be talking about, you know, how to make a particular joint or what saw to use, but it's also a chance for them to say, oh, and I'm not feeling really great today. So it doesn't happen. It's kind of indirect counseling, and it's peer-to-peer coaching. I'm a great, the evidence base for that model, I think, is growing all the time. Yeah. Yeah.
So basically what that man do is like giving examples about what are the things that they can, what are the things that the man can say, and then it's okay to say that.
Yeah, basically they do things, they create things, they are fixing things, and as indirectly they're kind of talking to each other about mental health on the side, but in a way that it's language that they're all comfortable with. It's not, they're not using jargon. It's not, you know, to do with psychology, but the focus is on the doing, because when you do it, you're not shaming and embarrassing yourself. You can talk about these things on the side, but the main thing is that you're doing something. And these men's sheds, we've got one at the community centre, but we call it a community shed. People go in to fix things and do things. And it has a really big impact on mental health and well-being and social cohesion. Yeah.
That's really interesting,
Isn't it
actually.
interesting?
Yeah,
Yeah.
yeah. Because it's like non-threatening ways.
Thank you, Sali. I should have said that. Absolutely, 100%. It's non-threatening.
And non-threatening, and also doing the things that they are comfortable with.
That's right.
Yeah.
And you're kind of using that as an indirect therapeutic advice. Yeah.
Sometimes that we also do with our children, like do some stuff with them and then asking about themselves, kind of stuff.
Oh, yeah. I totally agree. I think the best conversations I ever have with my daughter is when we're in the car and I'm driving and we're not looking at each other. Yeah.
So you're not feel threatened by me?
Yeah, I'm driving and she's telling me all this stuff and she can't see I'm, you know, horrified. Yeah, I agree. It's a good model.
Yes.
Yeah.
Okay, that's really interesting.
Thank you.
Yeah. So, okay, do we have any questions? One more questions?
Yeah.
Yes. Yeah.
Thank you so much. So my name is Nabila. I'm an undergraduate student. So last year we collected data about suicidal ideation among students here.
Amazing.
And University of Indonesia. And we found that at least 60% of students here have had suicidal ideation once in the last year. So it's very interesting because, oh my God, 60% is a huge number. And we also collect another data, for to know what is the risk factor. And one of it is the lows. What we found is most of the students here in University of Indonesia has a very low self-esteem about themselves, which is very interesting because why would they think why would they perceive themselves as a bad person while they're actually here in one of the best university in Indonesia?
Yes.
And
yes.
I know that's also because here in our community,
yes.
I have so many friends, and I'm one of them too.
Yes.
That, like kind of FOMO thing, like fear of missing out.
Yes.
And, if we hear someone already join like 5 organization, and we're kind of like, oh my God, 5 organization, and
I should do that. Yeah.
I should do that. And
Yeah.
then we just heard someone win a competition internationally, and then, oh my God, I should do that too.
Yes.
Oh my God, I just
Yeah.
like a small fish in a very big pond.
This is such a wonderful point. Thank you for sharing. I think there are 2 things. I think social media enhances our opportunities for social comparison, not helpful. But you know the other thing, and I see it all the time in my students, perfectionism. It is massive. It is massive. There's research evidence to suggest that perfectionism is on the rise. It's associated with anxiety and depression. If you get onto my researcher profile, you'll see a couple of papers on perfectionism, which I've done.
I saw one of your research.
Yeah, perfectionism. We've got to do something about it. Yeah, I see it in my classes all the time, and it's demonstrated in so many things like, why did I only get 84 rather than 85? you know, where did I? Yeah, perfectionism is, we've got to do something about it. Yeah, yeah. It is the bane of your generation. And I reckon social media is really big on this.
And actually, one of the reasons why we collect this data is to advocate for a policy in this university. So I was wondering, like, from your research, is there something that you would recommend to us to address those issues, like perfectionism or something like that?
So there are a couple of things, I reckon. Look up the work of Tracy Wade, W-A-D-E.
Tracy, I'm sorry.
Wade, W-A-D-E. She's done a lot on combating perfectionism. But the other thing too is, what's happening in my university is we are having, you know, mental health is such an issue with our student body. Basically, we don't have the resources to be able to do one-on-one sessions with every student. So I don't know what happens at UE, but what happens in Adelaide is we have lots of online resources, which students can go to basically, I won't say self-help, but you know, give them insights. So for early intervention and prevention, and we try to change the environment around us. So if you get in a lift in the psychology department, there'll be all of these posters up on the wall about giving messages directly about practicing, amongst other things, self-compassion. Yeah. So we're trying to change the environment to give these messages and make services more available online. Yeah. And so the students who get to see the psychologist, and we've got one psychiatrist on the team, that, you know, they're typically students who are further along the mental health pathway. Yeah. Yeah, but great work. Great work. And I don't know, I mean, universities, they don't want their students to just be mediocre, do they? They want their students to be top flight. So I think what happens is you get all of these messages. I'll give you another example. So this isn't being recorded, is it, Sali? Okay. One thing that I dislike intensely, oh, well, it doesn't matter. One thing that I hate intensely is the way that university life is marketed, okay? So you're given a whole bunch of messages, in my opinion. If you do this degree, you're going to change the world. If you do this degree, you're going to have an amazing career. One of the worst marketing pieces that we ever had at the university was a poster which was of a train going through a station and a boy running after the train. And the message was, you've got to catch that train, otherwise you're going to miss out. The subliminal message is, unless you enroll, you know, your life is. So I think you've got a lot to contend with that previous generations didn't. Yeah.
I'm sorry. But this is very interesting because if we try to lower the perfectionism in our generations, how about the competition? Like you say, that's the trait. Like, I mean, like, if we try to lower the perfectionism, that will affect the competitions atmosphere around the students. And how can we lower those while maintaining the competition? They can have a healthy competition without, because that's very important to our university too, right? Yeah,
I know. And I think it's particularly the issue in psychology. In my school, in order to get into the master programs, you have about 4 competitors for a place. So we've only got 10 places and we'd get 50, 60, 70 applicants per place. Yeah. So it's very difficult. What I encourage my students is to have realistic expectations, to apply to more than one program. Don't put all of your, you know, hopes on just one program. To have a backup plan, and finally, be prepared to have to reapply. You know, if you don't, and try to turn off that thing in your head, which is about make or break. If I don't get into this course, then that's it. You know, have a backup plan. I will go and do this for 12 months and then I'll reapply. But understand at the outset what you're dealing with. Look, all I can do is say, I hear you. Yeah, it is like that. Yeah, you are living in a deeply competitive environment. And I think you have to be purposeful in the way that you know, practice your self-compassion. Yeah.
Thank you so much.
So thank you. So I think that's the end of this session. Thank you very much, Deb. Thank you, everybody, for the questions.
Thank you.
So I think we learned a lot from here. Like there are, although there are differences between Indonesia and Australia, it's not. It turned out that some things are not that different. Like with the gender, like the gender roles, the way that gender plays a part in how people act and maybe feels. That also happens in Australia and also happen in Indonesia. We also talk about mental health, about the very competitive cultures that we live in, especially for the young ones, right? Yes. Yeah, I think actually, I mean, like I know from my other students, they are very competitive and they are very afraid if they don't achieve like A's for all the courses, they will fail and then they wouldn't get a good job and so on and so forth. So I think this is really interesting. So it tells that there's a lot of things that we can still research, we can still study to uncover the many layers of the how to improve mental health, how to improve physical health as well. And yeah, so I think that's all for today. Thank you very much, Deb. I really appreciate that.
Thank you.
Okay, please give another applause for all of us. And so, thank you. Okay, thank you.